Hi, you guys. Welcome back for our daily practice questions. As always, y'all know I like to first get into my introduction and disclaimer before getting started with our questions for today. So, for those of you who are familiar with me, hey, y'all. For those of you who are new here, welcome, welcome, welcome. I am Dr. Brittany Weinstock. I'm a family nurse practitioner, and I'm the founder and CEO of the Nursing Studio. I provide resources, tools, review courses, review videos, review books, Q banks, digital flashcards, one on one sessions, and more to assist nurses as well as nurse practitioners with success on their boards as well as in practice. Now, I've been doing this since 2015, assisting nurses and nurse practitioners internationally with exam success. I have maintained a 99% pass rate on all of my review courses and a 100% pass rate on any of my one on one sessions. Now, y'all know I like to go over my disclaimer and reminder that we know there's no absolutes in medicine. We treat on a patient by patient basis, and any of the questions that you see here or on any of my videos, I've designed and created based on the current guidelines that are being tested on the ANCC as well as the AANP exam. Now, any of my videos where I'm teaching on things that we currently do in practice, I'll always say that so there's no confusion. But with that being said, let's get into question number one for today. Question number one states, a 63-year-old male with a history of hypertension and diabetes presents with a painful unilateral rash on his right thorax. The rash appears as grouped vesicles on an erythematous base following a dermatomal pattern. The patient reports a burning sensation before the rash appeared. What is the most likely diagnosis? Is it A, chickenpox? B, the herpes simplex virus infection, C, shingles, aka herpes zoster, or D, tinea corporis. Take a moment and tell me what you got, you guys. All right, so y'all know I always recommend reading the stem of the question first to allow y'all to slow down to ensure you're answering what is even being asked of you. Here, the stem of the question states that the patient reports a burning sensation before the rash appeared. What is the most likely diagnosis? So the stem is what is the most likely diagnosis, right? Y'all know I always say if it's asking for a diagnosis, we got to run it back and look at the assessment findings. We need to see what's going on. What was their chief complaint? How did they present? What do we see on our assessment so that we can determine differential diagnoses, right? So this is a 63-year-old male. He has a history of hypertension and diabetes, and he comes in complaining of a painful unilateral rash on his right thorax, right? So, in your mind, this could be a little bit of anything. But this is that fluffy stuff that I tell you, and this is why I say to focus on the stem, because his hypertension and diabetes don't have nothing to do with this answer, right? And a unilateral rash on the right thorax is, okay, we're just thinking, I tell you derm, think location, location, but all right, we'll hold that, right? But here is the key. The rash appears as group vesicles following a dermatomal pattern, right? What is that classic for? Y'all should think, I say, when I say this, you say that. When I say vesicles following a dermatomal pattern, you should say shingles, okay? So the best answer is C, shingles, herpes zoster. All right, question number two. A 58-year-old female with a history of mild asthma is diagnosed with shingles. Her rash is within the first 48 hours of appearance, and she is otherwise healthy. What is the most appropriate treatment for her condition? Is it A, oral acyclovir for 7 to 10 days, B, topical steroids to reduce the inflammation, C, IV acyclovir for 14 days, or D, oral antibiotics to prevent the bacterial superinfection? Take a moment and tell me what you got, you guys. All right, so stem of the question here states, what is the most appropriate treatment for her condition? So, as always, I tell y'all, if we're looking for the treatment, you need to run it back and see if they provided you with the diagnosis. And in the event that they have not provided you with the diagnosis, then you need to run it back a step further and look at the assessment findings. But here they have. They told us that she was diagnosed with shingles. The rash appeared within the first 48 hours. So we're still early stages. So they're asking you, how would you treat this? So the best answer is A, oral acyclovir for 7 to 10 days. You want to go ahead and get that acyclovir on board. Now, you may ask, why didn't we go with C? First off, we're going oral. Second off, that's not your scope to provide IV, right? Remember, I tell you, even though you can do certain things, don't let these questions trip you up. because this is something that you may know that can be utilized. Follow the guidelines, follow the standard, and think about what you're doing in this office setting to be able to manage this patient, okay? All right. And question number 3. A 70-year-old male with a history of shingles presents for a follow up visit 2 months after completing treatment for his rash. He reports persistent severe pain in the affected area, even though the rash has healed. What is the most appropriate management for his post herpetic neuralgia? Is it A, amitriptyline, B, oral corticosteroids, C, antihistamines for pain relief, or D, a topical antifungal treatment? Take a moment and tell me what you got in the comments, you guys. All right, so still the question, what is the most appropriate management for his post-herpetic neuralgia? So instantly think about those first-line therapy for post-herpetic neuralgia. That's that that nerve pain that you commonly hear with people who have shingles, who they may continue on and on. You know, they sometimes just get triggered and don't have the active issue where they require like the acyclovir, but they continue to have that postherpetic neuralgia, that nerve pain, right? So amitriptyline is one of those first line therapies that we utilize for that. So I always say with shingles, we go A for acyclovir, and then we go A for amitriptyline for the postherpetic neuralgia. All right, you guys, I hope you found this helpful. As always, be sure to like, comment, and subscribe, and share with whomever you may think may find this beneficial as well. But y'all know what to do. Y'all make sure y'all meet me back here. And if you need any of the resources that I do offer, feel free to reach out to the nursing studio by giving us a call at 803-400-6864. You can also shoot a text message to this number or shoot us an email to thenursingstudio, the number 1 at gmail.com. All of the things that I do offer are linked in the bio of this channel, as well as my website. Again, I have taken down the one-on-one session access. I prefer y'all to either call, text, or email so that I can gauge what you truly need to make sure you're booking the appropriate session that is going to meet where you are. I know I say this often, but everybody's scenario is so different, and I do one-on-one specifically because I work with a lot of people who have been unsuccessful previously. And so sometimes y'all are just looking to get back in there to figure out what to do. And I want you to make sure you're doing the appropriate session for what you have. Some people are very close to passing and it was just a simple hang up. So you might not need uh, a certain plan that somebody else may need, who may need a full assessment of where you are, etc. So that's why I like to either speak to you so that I can gauge what you really need. And so that's why I always give that spiel. But all right, you guys, y'all know what to do. Y'all make sure y'all meet me back here. Happy studying. Bye, y'all.